Good afternoon, everyone. So I think we can go ahead and get started. So I'll go ahead and introduce myself. So hi, everyone. My name is Madeline Haley, and I would like to welcome you all to a very special webinar because it is our first collaborative webinar with the Autism Intervention Research Network on Physical Health, the AIRP. You might be familiar with our monthly webinars, and then also with the Healthy Weight Research Network, also the HWRN. Thank you so much for joining us today. Because of the number of participants, your audio will be muted throughout the call, but you can submit questions at any point on the Q&A chat or the Q&A feature or in the chat box on your console. Just a friendly reminder to please be respectful when communicating in the chat and asking questions, and only questions or comments pertaining to the presentation will be addressed. The entire webinar is going to be recorded and will be available on our website, which I will put in the chat. And you may also view the presenter slides to follow along on our Google Drive, which I will also put right now in the chat. There will also be a short evaluation survey at the close of this webinar. We invite you to provide feedback on this webinar and also to provide suggestions for future webinars. So in the interest of time, let's go ahead and get started. We would first like to acknowledge the Health Resources and Services Administration as the funding source for the AIRP. And it is my honor to introduce Dr. Carol Curtin of the Healthy Weight Research Network, who will be introducing today's speaker. Welcome, Carol, and welcome, Dr. Sharp.
Thank you, and thanks for the opportunity to introduce Dr. Will Sharp, who's a member of the steering committee of the Healthy Weight Research Network, which is a research network funded by the Maternal Child Health Bureau and HRSA, just like the ARP is. And we're really pleased to have the opportunity to collaborate with the ARP today about the topic on food selectivity and autism, which is receiving increased clinical and research attention. As I said, it's my pleasure to introduce Dr. William Sharp. He's the director of the Children's Multidisciplinary Feeding Program at the Marcus Autism Center, the Children's Healthcare of Atlanta, and also an associate professor at the Emory University School of Medicine. He's a clinical psychologist by training and specializes in the application of behavioral interventions to address a whole wide range of common but challenging childhood concerns. And as the director of the feeding program at the Marcus Center, he leads an interdisciplinary team that provides evidence-based comprehensive care for medical, behavioral, nutritional, and oral motor concerns associated with pediatric feeding disorders. And we're really pleased to have Dr. Sharp with us because he really is a nationally and internationally recognized researcher for his work and clinician for his work on the prevalence, cause, and potential impact of chronic feeding difficulties and related behavioral challenges in pediatric populations. And he's made significant contributions in understanding and treating feeding disorders in autistic children. And for that reason, we asked him to share his knowledge and his work with us for today's webinar. So without further ado, thank you. And I'm going to turn it over to Dr. Sharp. Thank you.
All right, I'm going to try to make this work. Thank you for the great introduction, guys. Happy to be here. I appreciate the kind words. Did this work? Give me a thumbs up if the screen came up. Awesome. Yep. So in the interest of time, I'm going to go ahead and jump to learning objectives. A few things. I've got a lot of ground to cover. I hope I can cover it. At the end of this, I want to show you guys some of the cool videos that we have of some of our treatment completers. I can't have that recorded, so I'm going to pause the recording of this talk so that we can watch the videos and then come back to together to finish up some Q&A. So goal for today is to understand the common patterns of food selectivity in children with autism and related developmental and medical conditions. I'm going to introduce this concept of good meal hygiene. It's a term that we're increasingly using at our treatment center, and what good meal hygiene involves, specific to autism, food intake and autism, and go over some of the strategies related to that hygiene for introducing new foods and expanding diets in children with food selectivity. And we will take questions at the end. Okay, so a little bit different format for this talk I've been kind of playing around with for a few years is kind of these big picture takeaways. So I want you to remember stuff, because a lot of people tune messages out, as the talk goes on. So takeaway number one is children with autism experience high prevalence of feeding concerns. And so the qualification there is it's highly variable in how we're estimating the prevalence of feeding concerns among children with autism. So probably the review I went to when I first got in this field way back in 2006 was Ledford and Gast, and they had kind of the best review at the time. And what they said is that anywhere between 46% and 89% of children with autism have a feeding problem. So either half or almost all have a feeding problem, which is pretty variable. We did a meta-analysis a few years later, about 7 years later in 2013, where we said estimates could be as high as 95%. So like we even went above the 80 or 90%, went to 85 and went to 95. If you go to the internet and you say, hey, internet, what do you get at in terms of this? The internet says about 80% of children with autism are selective eaters. So we'll go with the 80. But the point is, there is no consensus in terms of the overall prevalence of feeding concerns among kids with autism. And I think the reason that is the case is that we need better definitions and better assessment. And if you look at past studies, they varied on how the issue was defined and measured. So, sometimes they call it picky eating. Sometimes they say, does your child eat a variety of foods? Sometimes they say, will your child only eat certain foods? Fixated on recipes, prefer same food. You get the idea. So really, I have another study that's out where we looked at how you ask it determines what rate you get. Okay, takeaway number two. High prevalence corresponds with an unmet need for feeding intervention. So really, the access to evidence-based care is limited. There's no large-scale movement to develop and evaluate effective treatments, at least that I'm aware of thus far. And our group's been trying to solve for that. We know the prevalence of autism is increasing. It depends on what time you go to the CDC. You get an answer, but the most recent was 1 in 59 children meet criteria for autism. Now, the prevalence increase is debatable depending on why it's rising in terms of changing definitions, more assessment, and more community awareness. I'm not going to debate that, but I'm going to say, let's go with about 1 in 59. That would translate into about 1 million children in the United States with autism. I can do the math there, but so the math that I'm going to do is to say, how big is the unmet need for feeding? So there's 73 million children in America, 74 million children in America. If you go with that 1 in 58, you end up with 1.237 million children, 1.2 million. If you go with the internet's estimate of 80%, and I'm kind of being flipped there, but I'm kind of meeting in the middle between the 95 and the 50%, you get about 1 million kids with autism that could benefit from some type of feeding intervention. That's our best guesstimate. All right, take home number 3. Food selectivity is the primary feeding concern in autism. That does not exclude, the qualification there is that does not exclude other types of feeding concerns occurring in this population, but that's to emphasize it's the primary concern that you see among kids with autism. And as I talk about food selectivity, I like to talk about it in respect to what the government's recommended that we eat. And so, the My Pyramid, or what the pyramid approach got changed to the My Plate approach, which is this, beautiful plate with, fruits and vegetables and proteins, obviously, hopefully healthy grains and dairy. And that's really emphasizing the portion size that we need and kind of that variety we need. And so what does the plate of a child with autism typically look like? I've heard it called the white diet, or the starchy diet, but essentially most data that's out there suggests that children with autism prefer a diet of processed foods and foods that are basically coming from the starch and the proteins, and if they're proteins, they're usually processed proteins. Coinciding with a complete rejection or a more common rejection of fruits and vegetables. Many kids with autism will have fruits and vegetables on board, but they won't have as wide a variety of those foods on board as they do with the starches and those processed foods. I'm going to talk about ARFID in a little bit. What's really interesting about this pattern of the plate I just showed you and kind of this preference against fruits and vegetables in the ARFID literature from coming out of the eating disorders world is there is evidence that individuals without autism and selective eating show a similar preference for processed foods and grains versus fruits and vegetables. So it's not unique to this population. Showing you the rejection. I like this image of like why a potential reason we're having this gravitation toward away from fruits and vegetables and this preference for starches and processed food. Nature produces variability. It is that, I just picked some blueberries a few weeks ago off my blueberry tree in the backyard, gave them to my children. They said they don't taste the same as the big ones from the grocery. So they were sour. They were a little bit squishy. I'm not the best green thumb in the world. But when we buy crackers or chips, they tend to taste the same, look the same, and so forth. And there is a lot of anecdotal evidence. My colleague John Constantine does a nice talk where he talks about that the family rearranged the home and in the kitchen, and the child went on a hunger strike, basically because the insistence on sameness was changed in terms of the location and the look of the room. So just something to be mindful of as we talk about this. So I am going to take a detour to talk a little bit about ARFID and PFD. And I think this is an important detour for the field, so I'm going to take a moment to talk about it. So a little bit of background about ARFID. The DSM-4 had a diagnosis called feeding disorders of infancy and early childhood. And that was really our bread and butter for what we would diagnose. We would say, we treat feeding disorders of infancy and early childhood. Interesting facts about it: it required failure to gain weight or weight loss as a core feature, and it needed to occur before the age of 6. It was not associated with eating disorders. It was in a section entitled "Disorders Usually Not Diagnosed in Infancy, Childhood, and Adolescence." So different section, not associated with eating disorders. Jumped to the DSM-5. They introduced ARFID, and when they did that, they removed the predecessor's age of onset restriction, so no longer had to occur before age 6. It removed the weight loss as the lone diagnostic criteria by adding 3 additional manifestations. The DSM-5 still says it's more likely to start in infancy and early childhood, but it takes a lifespan approach. What is this going to do? Well, do it weird. So currently, ARFID is 4 things, and you can have more than one of these or just one of these. So if you have ARFID, you would have significant weight loss, significant nutritional deficiencies, dependence on enteral, so feeding tube or oral nutritional supplements, or marked interference with psychosocial functioning. So you're underweight or faltering growth. You have a diet-related deficiency because of your restrictive and avoidant food intake. You're dependent on feeding tube or oral formulated supplementation, or you're having such a significant problem related to life because of your relationship with food. I used to not be a fan of A4. So at my practice, we call it A1 through 4. So we'll say this child's an A1, an A2, A3, and so forth. We differentiate criteria 3 as being A3A and A3B to talk about where the dependence is coming from. But I've since come around. I've really gotten involved with more of the eating disorders groups around the country, and they've convinced me after that A4 is important. And I used to assume A4 couldn't stand by itself. You needed A1 through 3 in order to have an A4. But then I started meeting more A4s, and I'll give you an example of an A4. Had a child with food allergy who was fine eating foods, but just couldn't do it outside of the safe zone of his house. And so he'd go to school all day, starve, come home and eat in a very prescribed manner too. He had a certain way of like getting the food set up so it was quote unquote safe. And so anyway, he was an A4. He wasn't underweight. He didn't have nutritional deficiencies. He wasn't dependent on enteral feeding, but the way he was eating was so abnormal because of his fear of the consequences related to food allergy. Okay, so complicating matters. My friend and colleagues came up with this new PFD definition that is now in the ICD-10. So you have ARFID and DSM-5. You've got PFD and the ICD-10. After I kind of didn't understand what they were trying to accomplish, but since having re-engaged with them, I now know what they were trying to do. So this is a graphic that's available at Feeding Matters that I developed along with the Feeding Matters team. And it basically outlines the difference between ARFID and PFD. So with ARFID and PFD, they both highlight the nutritional and psychosocial. That's both part of PFD and ARFID. But what my colleagues felt like was missing from the ARFID definition was the medical component for kids who it's not safe for them to eat, but they're unable to eat because of aspiration or some type of medical issue. They were also concerned that there was kids who really lacked good feeding skill. They couldn't self-feed, they couldn't chew because of conditions like cerebral palsy or complex medical issues that make it difficult for feeding to be done efficiently. And they wanted to have a place for those kids to live. And so I'm on board with PFD now and ARFID, and I've done some work on trying to differentiate why they exist. All right, we're done with that. We can talk more about that if folks have questions, but that's my take home is that they both have a place. I think PFD is the overarching umbrella. I think ARFID is a subset of kids with significant avoidant restrictive food intake that's related to possibly a previous medical and or feeding skill, but those things need to be resolved for you to have that diagnosis for ARFID. Okay, takeaway number 4. Food selectivity has consequences, and these consequences range from mild to severe. So not eating a wide variety of food is not good for you. But the most interesting thing about studying feeding disorders in general, so going back to that initial definition of feeding disorders of infancy and early childhood, I noted that you had to have weight loss. So I actually didn't like that old definition very much because kids who would come to me with autism, they typically weren't underweight. I'd say, 8 out of 10 times, the weight was not the issue. It was that they were eating a narrow diet. It was causing their parents to be concerned about their growth and development from like a health perspective, but they weren't underweight. So I actually couldn't use that old diagnosis for this patient population. So I actually prefer ARFID. I'm a big ARFID champion in terms of allowing us to now see that kids with autism most likely are going to be an A2, that risk for nutritional deficiency, or an A4, that significant psychosocial dysfunction, because they're oftentimes eating enough calories to meet their overall nutritional needs. This was an exercise we did. I've been doing this for a decade or more, this kind of exercise, but on the left-hand side, you're going to see a plate that we developed that models the My Plate plan. And on the right, you're going to see a plate that models out a typical, food selectivity plate. And what you notice here is what you get is twice the calories, 4 times the saturated fat, half the dietary fiber. And then this plate on the right is missing all types of really key, nice nutrients. And the only reason you're getting any of those micronutrients, to be quite frank, is because we fortify food these days. So food fortification was successful in helping this plate at least make it across the finish line for some of these micronutrients. So what's neat about this slide, neat is the wrong word, but this is a slide about adults with autism. And what we were doing in our work was we were saying eating a selective diet will have long-term health complications when you get older. So as you get older, we're guesstimating that eating a bad diet is going to lead to things that you think of with a diet like that: hypertension, diabetes, obesity. And this was a large chart review that's now been published, I believe, of health concerns for people, for individuals with autism as they grow up. So this is comorbid psychiatric and medical conditions presented by my colleague, Lisa, I think I had it on here. She's with Kaiser Permanente is the key point. Yeah, Lisa Krohn, Kaiser Permanente, I've got that on the slide, good. In addition to, the really detrimental psychiatric comorbidities, you're seeing what we would think are things related to poor eating, obesity, hypertension, and GI issues. So that kids with autism and food selectivity grow up to be adults with autism and food selectivity if left untreated. And on the extreme end, we've seen scurvy, rickets, osteoporosis, things that are related, diseases of diet that you don't typically see in populations. We published this review not too long ago because we were so interested in the fact that we kept on finding case study after case study where people were coming in saying, can you believe this kid had scurvy? Well, it turns out there were 24 children in the literature over the past, 5 to 6 years, maybe I think it was the last 10 years, 24 cases of scurvy being reported related to autism and food selectivity. So that's really fascinating kind of intellectually, you would not expect that in a developed country like the United States. And we know beyond just thinking about the health implications that food selectivity is associated with high levels of stress and concern for families and specifically moms and dads, parents who are worried about their child's diet. In this good qualitative study, they basically said families are reporting they have to prepare multiple meals for the family, one for the child with autism and one for the family. We know that disrupted family meals, it's not pleasant when many children with autism are unable to stand the sight or smell or presentation of other non-preferred foods. So even if the parents are not asking them to eat those foods, it may be that just the presence of those foods on the dinner table will lead to some type of disruption that is interfering with the meal. We know that parents do report they're not going out to restaurants and they're not going to social events that involve food. If you think about, as human beings, food is essential to what we do on a daily basis. It's how we gather, how we celebrate. So those celebrations are being limited. And we know that parents are stressed out about this. They're telling us that through the qualitative work that's being done out there. All right. We are doing great for time. I'm riffing through some topics. I was hoping for 10 to 15 minutes at the end. I'm going to show some videos as well. I've got a good amount still left, maybe about 17 minutes. So we might have more time to just have a good conversation at the end. Takeaway number 5, behavioral intervention works. And this includes evidence that parent-directed and intensive intervention. So the evidence both of parent-led and intensive fits with autism. We renamed it, but we developed a parent training curriculum that we published in the Journal of Pediatrics that I'm going to kind of give you a preview of. And it worked out pretty well. About 47% of the kids had significant improvement through a parent-directed intervention at the end of the intervention versus 5% that received attention only, a parent education group. We've since revised it because I wanted to be a little bit higher than 50% effective. So we'll chat a little bit about that. We also know that intensive multidisciplinary feeding interventions for patients with food selectivity does work. So we can treat the scurvy and the rickets that we'd recommend with the intensive model, but we think parent training is probably going to be effective for the majority. If you do a bell curve approach, the majority of children can benefit from a parent-directed level of intervention. We're in the process of trying to scale that up right now, not from an implementation science perspective, but actually like get it out in the world and disseminate it through training. And I'm working right now on a grant to do that in the UK, which is pretty exciting. And we're doing some things with Children's Healthcare Atlanta as well. I can chat to that later on. We do recommend a multidisciplinary approach when a feeding problem is present. It doesn't mean the intervention has to be intensive multidisciplinary, but we do think it's important for you to involve a team of providers when you're starting to launch going down the rabbit hole of treating feeding. We think, a pediatrician needs to do a good medical assessment, basically clear the child to make sure there's nothing causing pain or discomfort. you know, a lot of kids without autism and feeding problems have medical conditions that contribute to the emergence and maintenance of feeding problems. So everything from reflux to food allergy that I mentioned earlier can cause you to have a significant feeding problem. So we do think it's worthwhile that you do rule out the underlying anything that causes pain or discomfort. My good friend and colleague, Tim Bowie, likes to say that children with autism have the right to be treated the same as children without autism in terms of being medically managed and not making it all behavioral. And I'm a big proponent, not everything in autism is behavioral. So go get assessed and make sure that there's nothing causing pain or discomfort. A dietitian should get involved to ensure proper nutrition. Behavioral intervention is a way to address the avoidant behavior and really work on establishing what I'll talk about in a little bit, which is good meal hygiene. An OT or an SLP, we call that feeding skill, should be looking at the skills related to feeding, chewing and swallowing and so forth, as indicated. We tend not to see feeding skill deficits as often in children with autism and feeding problems as we do with our medically complex. So children, the unique thing about children with autism is they typically come to us eating food, which as opposed to my medical counterparts with the really complex medical histories, many kids that come to me with a complex history of prematurity and significant medical complex cardiac cancer, so forth, they're not eating any foods and they're G-tube dependent. Children with autism come to us typically able to self-feed and chew food, which is way ahead of the game for some of the kids who are 3 to 4 who have not eaten any food at all. Okay. We are now, like I said, piloting out a new treatment approach and doing some training on this and working with treatment teams, taking what we did with meal plan and trying to really address that practice gap, you know, between research and practice, and not necessarily skipping the implementation science, but doing the implementation work as we move forward. But we took a bigger picture of meal plan to figure out like what worked and what didn't work. So this is our new treatment is called treating ARFID systematically through exposure, taste. I like acronyms, guys, so you're getting taste here. But there's a few things about meal plan that weren't ideal as we look to scale it. One is it was group-based. There's nothing wrong with groups, but we think some of the lack of effectiveness, you know, once again, 50% effectiveness, was due to the fact that you couldn't give much more focused attention to the family. It was a fixed duration, so it was 10 sessions and 3 booster sessions. Parents were responsible for all treatment. So we would basically teach the parent things and say, go home and try this. Child involvement didn't start until session 5. And we moved through the manual regardless of how the child was doing. It was a research study. We needed to make things happen in a short period of time. The reality is we changed it up to be individually based. Movement is proficiency based. We have the therapist first work with the child to show proof of concept and really get an idea of how difficult it's going to be to introduce new foods. Child involvement starts at session 1 at the very beginning. And we look for milestone-based progress as opposed to just kind of plowing through. So I'm going to talk a little bit about what taste is today. And really it's taking meal plan and giving it a lot more real world application, like how to and what it looks like. So taste goals. We want to improve parent-child relationships during meals. We want to introduce structure surrounding eating at home. We want to increase child flexibility with food, and we want to identify and establish intake of socially and nutritionally meaningful new foods into the diet. But we start with the parent-child relationship, and that's really the foundation. What we know is that a lot of parents will come to us and they'll say, this has been such a traumatic experience with us with this food selectivity and the mealtime disruptions that we're not even trying to introduce foods anymore. It's too stressful for us. And so and if they are trying to introduce foods, they're doing so in a way that the mealtime, the table itself is becoming aversive because the child associates the table with the presentation of non-preferred foods, and their overall is a lack of structure and scheduling and all so forth. So we really spend now the majority of our early work getting that structure in place and getting that foundation in place before we even care about introducing new foods. So that's the other thing. I've kind of philosophically moved away from saying the goal of treating food selectivity and autism is about expanding the diet. And I've now said The goal of treating food selectivity and autism is about empowering parents and children to make positive relationships with food and to get that structure in place. And the rest of it should just, in terms of how we introduce food, that's part of the equation, but targeting foods is not the only focus of the intervention. Okay, so kind of going along with those goals, TASTE has 3 phases. Phase 1 is we want to achieve nutritional stability and establish good meal hygiene. Phase 2 is we want to do food exposure and expand the diet through behavioral intervention. And phase 3 is generalization and adoption of the treatment approach and ownership by the caregiver and child. So these 3 phases, we'll stick in a phase for, it no longer is like that we'll just move through and say, we're done with phase 1, let's move to phase 2. We're going to stick to phase 1 until we get that good meal hygiene, until we get that nutritional stability. And I'll explain what that means in a second. It's same thing with phase 2 and phase 3. So I'll pause there, let folks look at this for a little bit more. All right. Meal hygiene. This is how we're defining it. A consistent pattern of eating that follows a regular schedule of meals and snacks, involves an adequate level of consumption in terms of volume, and increases positive social interactions while minimizing conflicts around eating and meals. I do want to highlight my colleague that will be joining me, Hannah Zitgraf. She's an eating disorders ARFID person, but she and I have been collaborating on this idea of meal hygiene, and she's helped me craft this definition. So let's unpack that. Good meal hygiene, follow a regular meal and snack schedule without grazing. Grazing, we'll define that in a second. Eating an adequate volume of food during meals and snacks at a consistent location within a reasonable time frame. So snacks, meals and snacks, consistent location, reasonable time frame, and positive family members interacting while eating. So reducing arguments and really improving that parent-child interaction. So meal schedule. I didn't make this up. This comes from the world of dietetics. 3 meals, 2 snacks a day. Meals and snacks should be spaced about 3 to 4 hours apart. It's good to space them apart because it promotes good digestion and it promotes hunger. And eliminating grazing is an important thing. Grazing is defined as unstructured eating throughout the day, most often involving snacks, sweets, or processed foods. So I believe these slides are going to be available because we're recording this. But I'll be happy to provide these definitions to anybody in the audience who wants them, but they're not official. Grazing might be. Meal hygiene, we haven't published that one yet. So here's the weird thing about what we're doing. And weird, I mean, it's not that weird, but it is something, a twist. So the first thing we're doing in TASTE is we're making preferred foods the meal. So this means that we're embracing this plate at first. Now, is that ideal? I already showed you how bad that plate was for you from a nutritional perspective, but we're embracing it. We're embracing it because we're trying to get the child back to a place with their relationship with their parent in the meals that they'll come back to the table and they will eat the portion size presented. Now, we probably wouldn't present that much food, but you get the idea. We also encourage the families to consider all the food in the child's diet. We know that parents tend to underestimate how much their children actually have from a dietary variety standpoint. And it's because they're so fixated on what the child won't eat that they oftentimes neglect foods that the child will eat. As an example, we often have families say, oh yeah, he eats applesauce. Oh yeah, sometimes he'll eat apples, or he'll eat a banana once in a while. Those are foods that should be part of this plan that is about, we call it preferred foods, or foods that the child will willingly and seeks out eagerly, and accepted foods are foods that the child's fine with. They're not like, the top, top of the line, but they'll eat it if presented. And we want to make those foods the foods that we're first targeting during meal hygiene. So big idea here is don't present non-preferred foods at first. Present preferred foods and work on getting the child back to the table and the parents being able to practice good interaction with their child. So we, for those of you who are like in the PCIT world or parent-child interaction therapy, we're basically using, good behavioral interactions with parents and children based on the principles that we know work best, which is, giving good labeled praise, limiting commands, but making them effective instead of ineffective. So like label praise is like, good job rotating through your foods, nice job sitting in your chair. I love how you're still focusing on your meal while chatting. Effective commands tell you the child what to do versus what not to do. Like, don't ask questions, stop shaking your leg would be a negative versus please return to the chair, take your bites, versus stop goofing around. Lead also focuses on acknowledging successes. We find that oftentimes parents will discount that their child's doing something well because they're so frustrated that their child won't eat a variety of food that we say, slow down, let's acknowledge the incremental successes we have. And then I'm a big fan of differential attention, which basically means we ignore the things that we can ignore in terms of whining, crying, minor interruptions, and we really focus on celebrating those successes. And I'll show you what this looks like in a little bit with the videos. Cool, from a time perspective. Okay, I mentioned this before. When we move to exposure work, really starting with meal hygiene, we're going to differentiate preferred foods, accepted foods, drop foods, and non-preferred foods. Preferred foods are foods that the person willingly and regularly consumes without prompting. I defined accepted foods for you already. The one thing I want to highlight is what we call drop foods. And these are foods that the child recently ate, but is no longer accepting. Drop foods are important because drop foods are probably the place I'm going to recommend you go to first when introducing, when trying to expand the diet, because drop foods have the most recent experience with taste exposure and so forth. And then there's non-preferred foods. These are foods the individual consistently rejects and or avoids and whose presence may cause distress. Now, I'm a big fan these days of letting people have preferences. I think in my early days, I was like, our job is to get non-preferred foods on board. It's not, no. I think the only time that we would target foods that are really not well tolerated is if there's, if you've got scurvy and you won't eat anything and you're in the hospital, we might have to be a little bit more creative with our food list. But we tend to shy away from non-preferred foods these days and accept if they are sensory characteristics that are similar to preferred foods or accepted foods and that they don't cause a lot of distress. So basically minimize distress is my key takeaway. The other thing that I often note is if you end up doing behavioral observations of families with kids with autism and food selectivity, they oftentimes present the food as if the child likes to eat it. So, it's not uncommon for us to say, show us what you're doing at home, and they'll bring out an entire bowl of green beans and like put it in front of the kid. So one of the exercises we do when we work with parents and therapists and training this model is we say, put yourself in the shoes of a child. I like to do what's called the disgust, I think we call it the what foods do you hate exercise. And you basically think about a food you really, really hate, right? Think of something that's really disgusting. Everybody put that in your head. Mine used to be mayonnaise, but I did some exposure work. I no longer hate mayonnaise. Mine's now beets. I don't like beets. Oh my God, they make me vomit in my mouth when I eat them. But the point is, if you put a bowl out of whatever you hate in front of you and the bowl's full, you're communicating to the child and to you as an individual that you're supposed to eat that entire bowl. So one thing that I want you to think about when you're working with children with autism is don't put demands on them that are unreasonable. And putting an entire bowl is like asking me to eat a bowl of beets. I'm going to punch you and run away from the table if you're asking me to eat beets. I'm upset. So the way we present foods is really important as well, in addition to hygiene. And like I said earlier, the table becomes associated with the place that these foods come out, and these overarching high demands come at you. And it's like bringing, you're bringing the heat to these kids who really are telling you through their behavior that this is overwhelming to me. So I'm a big fan of presenting a reasonable demand. When we get to the exposure work, we start small. We go with a small bite size and a bite number. We gradually increase the demand. The increase is based on success. That is, the child is consistently and willingly consuming. The biggest error that I see from a therapeutics perspective, as well as during parent training, is the child takes 2 bites in a small, very small bites, and the parent just starts like scooping it, making the bites bigger, really increasing the demand incrementally. My advice is go slow, celebrate small incremental successes, use data to guide and track the process of increasing the demand. And then you drop it into the meal once you're hitting target portion sizes. So don't go from, I just took a few bites to them presenting a portion. You gradually get there by building on that success. So, this is an idea I've seen parents present, full spoonfuls of yogurt to their child. When we're working with yogurt, we might begin this small or even smaller. And then we would, we'd fade up from there in terms of building on that success. What we do now in terms of that third phase so that was exposure work to get you an idea. We start small, we will focus on accepted and drop foods, potentially foods that are non-preferred, but are more aligned with foods the child currently eats. And then when we get to generalizing the caregivers in our third phase, we demonstrate first with a therapist in a room. That is, the parent will demonstrate it, that they can do it with the therapist giving feedback and training. And then we pull out and we demonstrate independently at clinic. That is, we have one-way mirrors. If you don't have one-way mirrors, you can get a great baby monitor that has the technology is amazing these days, but you can use something that lets you get out of the room. We want to show that the parent alone can do it without the clinician present. And then we have them go introduce new food at home independently without any support from the therapist, other than coming back to the clinic to say how it went. All right. I actually am not ahead of schedule. I'm sort of ahead of schedule, but what I'd like to do is pause the recording and show you what this.
Yeah, thank you so much. This was a really great presentation, and thank you to the patients and their families for showing that. Thank you for showing that, because I think that was really it's good to kind of demonstrate those real results. So I'll go ahead with some of the questions in the chat box. So the first question is, and there's also kind of a follow-up question after this, but how do autistic adults with restrictive eating fall into the ARFID definition? I've met many fellow autistic adults who have very restrictive eating patterns and self-identify as having ARFID.
Yeah, so the first thing they would need to do is what I recommend, if a child, any person with autism and food selectivity, they first need to figure out if they have A2, that is nutritional deficiency. So they probably need to figure out if their diet's so narrow that they have nutritional deficiencies, and that would land them in the A2 ARFID world. The other piece was, if they don't have A2 and they're not underweight, then the question then becomes, is this causing significant psychosocial dysfunction for them? That is, are they not able to go to restaurants? Are they not able to eat at social events? And that's really what you'd be targeting with treatment of ARFID in adults with autism and food selectivity.
Thanks. All right, so the next question is, curious to what mealtime structure you are teaching parents to do at home, both the family meals and the practice meals and food exposures. You went a little bit into that, but I don't know if there was any other details that.
Yeah, so what we do, so to kind of give you an idea, is meal hygiene is establishing 3 meals and 2 snacks. So, and getting it back to the table and making preferred foods the meal. Because the kid's eating preferred foods anyway. And I think I forgot to mention that oftentimes parents are underestimating how much the children are eating during the day from a snack food, because they tend to discount snack food as snack food. So our first thing to say is snack food is food, and you need to present it at regular intervals and not let the kid carry around chips all day long. So that first work at home is really about that structure of when food's presented, how food's presented, and what food's presented. And then the exposure work in terms of expanding diet occurs at clinic. And then once we get a food being consumed without distress and at a level that is portion size, then we say to the parent, hey, this is a food your child now eats regularly. Let's incorporate it into those preferred food meals at home. And so then you transition the food into the meal that way, as opposed to trying to blast the kid with a bunch of new foods at the dinner table.
Thank you. And then there is a kind of a follow-up to the last question about autistic adults who identify as having ARFID or challenges with certain foods. Have there been any kind of efficacy at the parallel systems
That's a really good, it's a
Yeah.
really good question. Totally get it. So the first thing to think about is that most adults with ARFID are being treated at eating disorders programs. Eating disorders programs tend to treat ARFID kind of like anorexia and bulimia until recently. So they didn't really know how to go about it. The research coming out of that world's in its infancy. And if you look at any of the things with the eating disorders community talks, I only go to 21. So by being in a pediatric setting, I can't investigate treatments in the adult populations. I would assume many of the things that we are espousing in terms of good meal hygiene, gradual exposure would work. I just don't know of any treatments that are in development and or there's none well established, and it would be coming out of the eating disorders community, and that work is very, very early on, and primarily involves females, akin to what you'd find in the eating disorders community in general.
Thank you. And then another question is, are there patient and family-facing tools freely available online that demonstrate some of the core behavioral strategies that a family can start with while, for example, waiting to get into a multidisciplinary or a more intensive feeding program? That's a really good question.
No, not that I'm aware of. There probably needs to be. We did publish something recently. That graphic that I showed you about, that came out. I end up doing things and I don't know who they're really, sometimes I'm like, oh, that was cool. But we did publish something that was a general handout for caregivers that should be widely available through an organization that escapes me right now, but I'd be happy if you want to contact me. I could send you that link that just basically talks about meal hygiene, about how to introduce new foods. I don't know if it was a magazine or a parent forum. I forget exactly what I was doing.
Yeah, I was going to say, it would be really great to have additional resources, because I can imagine that in some programs it might be a little bit difficult to get into, but yeah. And then another question is, do you see any patient characteristics or rationale for whom taste could be or would be recommended as the primary treatment approach as opposed to CBT, AR, and vice versa?
Oh, interesting. Yeah. So taste is really designed for a restricted diet that is the focus of, so it's not meant to be talk therapy. Let me just say that, cognitive behavioral therapy. We are not, but it's more talking than we do in our ABA world. So I didn't mention that if, the things I didn't mention about taste, for individuals who are verbal and like to communicate, it does involve choice. So there's a CBT-ish type of thing to it. We have a publication coming out showing kind of how it relates to CBT. It's a lot bigger B than a C, so it's a big B, little c, but it does involve some CBT. I don't think there's many other, I think I saw Emily Kushner on here as well. I know she's done some really great work with her work looking at kind of the buffet program. I'm not sure, Emily, you and I should have a conversation whether how buffet lends itself to taste. I haven't really thought about that. But I believe buffet is more of a CBT approach. I think that's a question to be determined through future research, to be quite frank. I don't know if we know enough yet. It's in its infancy.
Sure. All right, we got actually one in the chat that's a good question as well. Given the high prevalence of food selectivity, should PCPs offer a preventative approach to parents of kids with ASD soon after the diagnosis? Like, for example, sharing the taste protocol before the problems emerge?
Yeah, that's a really good question. So what I can tell you what we're doing locally. We at the Marcus Autism Center have embedded a dietitian into our assessment clinic. And every kid who comes in for an autism diagnosis assessment also gets a nutrition evaluation to figure out if they need nutrition services and or behavioral, our services. I think that feeding screening should be part of every diagnostic site. That would be ideal in my mind because it is so prevalent. And so we do ask the questions, how do you have concerns about meal times? What is the child currently eating? What are strategies? From a PCP perspective, it'd be great if the frontline providers are screening. We are seeing one of the things we are seeing an increase in, this might just be our site itself, but we're seeing a lot more use of nutritional supplements like Pediasure or Ensure as a way to make sure there's no underlying nutritional deficiencies. One problem with that is that it tends to become leading to A3B, that dependence on enteral feeding, because the kids tend to like it and they drink it a lot. And so I'm not a big fan of that prophylactic nutritional supplementation unless there's an underlying nutritional deficiency.
Thank you. Next question is kind of another kind of two-part question. Do you see any variability in the program outcomes based on the severity of ASD? And also, are there any other factors such as sex or the age of children responding to your program better?
I can say that we have been looking at when it doesn't work, there tends to be comorbid behavioral concerns that we didn't know about. So TASTE is not meant for kids who have behavior problems during and outside the meal. We often say, please go work on those foundational behavior management skills outside of meals, and then come back to us. From a gender perspective, obviously we are seeing a lot more males than females because of the distribution of gender and autism. I don't know off the top of my head. I don't see one approach being better than the other in terms of gender. I will say it's been pretty cool to test this out because we are seeing similar outcomes among children with lower IQ scores are benefiting from it just as much as the highly verbal. The treatment looks a little bit different for lower IQ in that there's less cognitive engagement, not because we don't want to, it's because the verbal language isn't there, at least from a choosing your foods and engaging that process. But thus far, this whole idea of establishing good meal hygiene appears to be equally effective from what we can anecdotally tell you at this point with rolling it out locally in our clinic and rolling it out at a few places around the country.
Thank you. All right, I think we have two more questions, and I think that's probably all we'll have time for. There's one a little bit longer question. I'll leave that one for the last one. But the other question that just came up was, are there any components of taste that address very strong hunger, food fixation, or hyperphagia?
No, is the short answer. And I think taste would not be appropriate for that type of issue. I think we probably need a different approach. So I'm not trying to paint taste as the end all be all. I think that would require a much more, a much more multidisciplinary approach. Taste is largely behavioral with a little sprinkle of nutrition.
All right, and then we'll end with this question. Seeing that many children with ASD who are selective eaters receive treatment in private practice settings and not in intensive feeding programs, how does this treatment in a private practice differ than in the intensive feeding programs? And then how can therapists who are on limited time still provide effective therapy in 30 minutes twice a week? Should they focus more on parent education? I know that's kind of that's a big question to leave everyone with, but
so the cool thing about what we're doing here is we had implementation science in mind when we got done with meal plan, and we've been since testing this out with different provider types and seeing what modifications we need to use. We're currently have BCBAs, board certified behavior analysts, running it in a typical clinical setting without a multidisciplinary team, and it seems to be working from the anecdotal data we have. We are piloting it with BCBA providers in other locations outside of the multidisciplinary program. We got a clinic in Savannah that's rolling out to right now, and it appears to be working. Now, I haven't rolled it out to SLPs, but that's probably the next provider group that needs to try it. I know we got 2 minutes or less. I know there's a lot of treatments out there that you can get trained on. A lot of feeding treatments, SOS. I don't want to brand too many other ones, but SOS is probably the most well-known one. What we're trying to be a counterpoint is we established this through research, and now we're trying to see what it happens when we offer it to the community to implement. We have a training that we're doing kind of a small rollout right now to see how it goes. And thus far, all signs seem to be pointing to the fact that it seems to be disseminable, if that's the word, to places outside of intensive multidisciplinary clinics. That long-winded answer is we think it's going to work.
Thank you so much, Dr. Sharp. Do you have the slides with the presentation for next month?
Oh yeah, hold on. Let me bring that back up.
Well, I think the first it might be the contact information.
That is not the right one, so let me stop sharing it.
No problem.
Okay. That's meal plan. Did I close it out? I might have. Let me.
No problem. I can actually share it from my screen. I have it open right now.
Okay.
So. Oh, sorry about that. Just 1 second. There we go. All right. So here is our, first of all, thank you, Dr. Sharp, for that amazing presentation. That was really great. And here is our contact information for AIRP and also for the Healthy Weight Research Network. There is a feedback survey. So here's the QR code. I will also put it in the chat. And then we also invite you to follow us on social media. We have all of these links. These are also available on our website. And also, finally, we have our webinar on July 19th with Dr. Dora Raymaker, and I'll go ahead and provide the link for that as well. Sorry, I realized I didn't leave it up for very long. And then the link is the link to register for next month's webinar is right here. And thank you so much again, Dr. Sharp and Carol, and yeah, have a great rest of your day.
Thanks very much. Great talk, Will. Appreciate it. Thank you.
Thanks, everyone.